an online webinar. We have this program every second Tuesday of the month, and we are looking forward to today's program. We have the blessings of our FOGSI President, Dr. Sunita Tandulwadkar ma'am, and our FOGSI Secretary General, Dr. Suvarna Khadilkar ma'am. We have among us ICOG Chair, Dr. Parag Biniwale sir. Sir, can I request you to say a few words?
Thank you, Pradnya. Good evening, all. I bring greetings from ICOG, and it's indeed a pleasure to address the gathering for the last episode of this year of FOGSI ICOG JOGI Research Methodology Program and Journal Club. So, at the outset, let me compliment and congratulate Dr. Sujata Dalvi, who's the editor-in-chief of JOGI, and Dr. A.G. Radhika, who's the governing council member of ICOG, for conceptualizing this program and taking it ahead. Of course, I appreciate the young dynamic team of the journal, Dr. Pradnya Changede, Dr. Pradnya Supe, and Dr. Sunil Tamvekar, who've been very active in this program and helping us conduct this program and coordinating all the activities. A special welcome to our two presenters today, Dr. Jinal and Dr. Nalini. Welcome to the ICOG platform. And I warmly welcome ex-chairman of ICOG, Dr. Tushar Kar. I had the privilege of working as the secretary of ICOG with Dr. Tushar.
Thank you. Thank you for that.
Yeah. And the chairperson-elect, Dr. Sheila Mane, along with Dr. Alka Pandey, who had been a governing council member of ICOG earlier, and Dr. Hafizur, who's yet to join. So this, of course, the two presentations will be followed by a lecture by Dr. Rajeshri Katke, who will be talking about the professional manuscript writing and softwares which help us in writing manuscripts. So I'm sure it's going to be a good experience for the postgraduates, and this will be really helpful for them for the future. So thank you very much, all of you, for joining, and my best wishes for the program.
Thank you so much, sir, for always encouraging us. We have our two conveners for today's program, Dr. Sujata Darvi ma'am, who is the editor-in-chief of JOGI, and we have Dr. A.G. Radhika. Madam will be joining us shortly. She is also a national corresponding editor for JOGI and ICOG governing council member. So, Sujata ma'am, can you share a few words with us?
Yes, thank you, Dr. Pradnya. At an outset, on behalf of myself and my co-chair, Dr. A.G. Radhika, who will be joining a little late, I welcome one and all for this FOGSI ICOG JOGI Research Methodology and Journal Club webinar. At an outset, I would like to express my gratitude to FOGSI President, Dr. Sunita, FOGSI Secretary General, Dr. Suvarna, and of course, ICOG Chair, Dr. Parag, ICOG Chair-elect, Dr. Sheila, and Vice Chair, Dr. Ashok, and ICOG Secretary, Dr. Sarita. I would also like to express my gratitude to two important persons from our journal team, Dr. Pradnya Changede, who is a convener of today's program, and Dr. Sunil Tamvekar, who is a master of ceremonies for today's program. Both these people from our journal team are very hardworking, and they are always ready to help. So I must express my gratitude to both of them. Of course, my gratitude to all the chairpersons and the today's speaker. They're going to be speaking. One is going to be speaking on transfusion protocol, the other one on thyroid. Both these topics are very important from clinical point of view. And we have a speaker who is going to talk on writing the manuscript. So let us just go ahead, because Dr. Parag has already elaborated on what they're going to speak. So let us just go ahead with today's program, Pradnya. Over to Dr. Pradnya.
Yeah. May I now request Dr. Sunil Tambekar, who is the master of ceremony for today's program, to introduce the experts for today's session, and they will introduce the speakers.
Thank you very much. So before going ahead, our warm welcome as well as thanks to our senior leaders from FOGSI, Dr. Sunita Tandulwadkar, madam. She is currently heading FOGSI. She is the president. Dr. Suvarna Khadilkar, madam, general secretary for FOGSI. Dr. Ashok Kumar, sir, he is vice chairperson ICOG from Delhi, and Dr. Sarita Bhalerao, madam, secretary ICOG. Now I move ahead with the program. So dear students, delegates and faculty, research is nothing but standing on the giant's shoulders. So that is searching the unknown within the known. And these are the principles we are following and doing day-to-day basis at JOGI. So once again, warm welcome to all of you. I would like to introduce today's experts, the chairpersons for the session, the National Journal Club. Dr. Tushar Kar, he's senior obstetrician and gynecologist and senior leader from FOGSI. He's professor and HOD at SCB Medical College, Cuttack, Odisha. He has been chairperson ICOG 2019-20 and of course vice president FOGSI 2010. We welcome you, sir.
Thank you. Thank you. Thank you, Sunil.
Yes, sir. Dr. Professor Sheila Mane. She is again senior obstetrician and gynecologist and a senior leader at FOGSI. Importantly, she is ICOG chairperson elect. And she has been vice president FOGSI 24 and senior figure from Bangalore, president BSOG 2005 and 2006. We welcome you, madam. Dr. Alka Pandey, she is senior obstetrician and gynecologist. Madam is professor and HOD at Lord Buddha Kashi Medical College, Saharsaha. So she has been vice president FOGSI 2022 and 23, ICOG Governing Council 21 to 23, and many accolades on her credit. We welcome you, madam. Dr. Hafizur Rahman, we just received a message from sir that he is busy with NMC inspection, so won't be able to join, but intermittently he will join. He is professor at Sikkim Manipal Institute at Gangtok and now member ICOG Governing Council. We welcome Dr. Hafizur. So let us have a ball rolling, and I request chairpersons to have first presenter introduction, and we'll start the journal article presentation.
Yeah, Sunil, should I introduce?
Yes, sir, go ahead.
Yeah,
Yes,
the
sir,
first
please go ahead.
To clear, she is the senior resident of Nair Hospital. You know, after MBBS from Rajiv Gandhi Medical College, she has done Master of Science from Obstetric Gynec from TNMC and BOL Nair Charitable Hospital this year. Currently working as senior resident in Obstetric Gynec at TNMC and BOL Nair Charitable Hospital. So she will be dealing with the transfusion medicine practice. As all of us know that, you know, for a practicing obstetrician, starting from a postgraduate, resident, even a consultant, professors and all of them, this transfusion medicine in obstetric is very much required. Well, we know that not only in the antenatal period, but even prenatal period, antenatal period, intranatal period and postnatal period, the requirement of transfusion is quite necessary. But we know that it must be judicious and prevention is better than cure must be taken into respect. But before going to the transfusion medicine in obstetric practice, I must tell one sentence that a bottle of blood can save a life, but a drop of blood can take away life. I repeat again, a bottle of blood can save a life, but a drop of blood can take away life. So therefore, we must be very much judicious, and prevention is better than cure. I always tell that. Now, podium is yours. So you have to deal with the transfusion in medicine, our obstetric practice. Go on.
Thank you, sir.
Welcome, Dr. Hafizur.
Thank you. Thank you so much.
Yeah. You can start, Dr. Jinal. Please start.
Yes, sir.
Make it full screen.
Yes, sir.
We can see your slides. Just slideshow you will have to start, Dr. Jinal.
Yes, ma'am.
You can, press shortcut F5. That will serve the purpose.
Yes, yes, sir. Sir, wait a second. Sir, is it visible?
Yes, yes,
Yes.
it's visible.
Okay. Good evening, everyone. My name is Dr. Jinal Tuklia, and I'm here to present my thesis topic, that is observational study to analyze transfusion practices at a tertiary care center in adult population, that was published in the journal IJR-COG, October 2025, volume 14, issue 10, page number 3358, under the guidance of my co-author, Dr. Shailesh Kore sir. So blood transfusion is one of the 8 essential components of comprehensive emergency obstetric care and plays a critical role in reducing maternal mortality. Obstetric hemorrhage, particularly postpartum hemorrhage or PPH, remains a leading cause of maternal morbidity and mortality worldwide. Anemia and coagulation disorders further increase the risk of severe bleeding during pregnancy and delivery. My study aims at improving transfusion practices and also to deal with the reactions associated with it. Timely and appropriate transfusion of blood and its components is vital in the management of obstetric complications, identifying high-risk patients, and ensuring adequate blood component availability can significantly improve the maternal outcomes and reduce the mortality related to obstetric hemorrhage. Introduction. Blood transfusion has always been central to comprehensive emergency obstetric care, significantly reducing the maternal mortality. Anemia, as defined by WHO as hemoglobin less than equal to 11 gram per deciliter or hematocrit less than 32%, becomes clinically important when HB level falls below 10 gram per deciliter, necessitating further evaluation and treatment. Obstetric conditions most commonly associated with severe bleeding include placenta previa, placental abruption, and uterine autonomy. Postpartum hemorrhage accounts for approximately 25% of all the pregnancy-related deaths. My study will enlighten the indications of transfusion in pregnant patients, the various components that are transfused, and also the transfusion reactions. Protocols such as massive transfusion protocols, that is PRBC ratio is to FFP is to platelet ratio, 1:1:1, and fluid resuscitation are essential to avoid coagulopathy from large volume crystalloid use. Postpartum hemorrhage is defined as blood loss of more than 500 ml in vaginal delivery and more than 1000 ml in cases of cesarean section. The 4 leading causes of PPH are uterine atony, accounting for 80% of cases, followed by trauma, placental disorders, that is tissue, and the thrombin, that is coagulation defects. So methods. This was an prospective observational study that was conducted in the Department of Obstetrics and Gynecology at a tertiary care center and medical college. The study period was for 18 months, starting from the approval from ICOG committee. My inclusion criteria was pregnant women ready to participate 18 to 40 years of age and who received blood and blood product transfusion for various indications related to pregnancy during antenatal, intrapartum or intraoperative or postpartum period. My exclusion criteria was first, women receiving blood or component transfusion for incidental or accidental causes not related to pregnancy. Second, women receiving transfusion before the diagnosis of pregnancy and or before admission to hospital. Third, women who receive transfusion from outside and has been referred to our hospital for some reason. Sampling material and method. So this was a prospective observational study, as already discussed, carried out on 150 consecutive women who received transfusion of blood and blood components at Topiwala National Medical College and BYL Nair Charitable Hospital. My study period was for 18 months, starting from Jan 2023 to June 2024. Data was obtained from patient indoor sheets, ward admission record books, and blood bank requisition form and records. These papers were analyzed for indications of transfusion, types of component that was used, number of units used, and the outcome of the patient. Antenatal, labor, perinatal, and postnatal records all were collected from PNC and the labor wards of Department of OBGY, Tertiary Medical Center and Hospital. Statistical analysis was performed using Microsoft Excel 2021 software, and the level of statistical significance will be set at p-value of less than 0.05. Appropriate statistical software, SPSS version 25.0, will be used for statistical analysis. So these are my results. The first table demonstrates the distribution of study subjects according to the age. So as seen from the table, majority of the patient, that is 46%, who received transfusion belong to the age group of 21 to 25 years. The incidence of transfusion in the age group of less than 20 years was around 17%. Age group 26 to 30 years was around 25%, and only 18 patients who received transfusion were more than 30 years. Apart from that, even out of the total 150 women, 53 patients were primigravida and remaining 97 were multigravida. In our study, out of the total women who received transfusion, 49% patients had a normal full-term vaginal delivery. Around 48% women had a lower segment cesarean section, thus suggesting a balanced approach between these two delivery methods in the study. And remaining 4, that is 2.8% of the patient had an instrumental delivery. The most common indications for blood transfusion was found to be anemia, accounting for nearly half of the cases, that is 48%. Postpartum hemorrhage or PPH accounted for 12.7% of cases, out of which uterine atony was the most common cause of PPH, accounting for 6.6% of cases. Traumatic PPH being the second most common cause, accounting for 4% of cases, and adherent placenta accounted for 2% of cases. Thrombocytopenia and coagulopathy were significant other indications, representing 20% and 14.7% of transfusion respectively, as can be seen from in this table. Then this is a table demonstrating the distribution of the study subjects according to the components transfused and the number of the each component transfused. Out of the total 150 women in our study, about 76% women received a packed cell volume or PCV, 24.7% received FFP transfusion, 20% received platelet transfusion, and only one, that is 0.7%, received a cryoprecipitate transfusion. Out of the 76% of women who received a packed cell volume transfusion, 32% of the women required 1 unit of PCV, 26.7% required 2 units, 10.7% required 3 units, 5% required 4 units of PCV, and 0.7 and 0.7% patients required 6 units and 9 units of PCV respectively. This table demonstrates the distribution of study subjects according to the maternal outcome. As we can see in this table, the outcome, about 81.3% of the patient experienced a normal puerperal period. There were 9 cases of maternal mortality, 8 cases required an obstetric hysterectomy, 7 cases underwent exploratory laparotomy, 3 cases underwent vaginal exploration, and the least common procedure, suction evacuation, was performed for 1 case. This table demonstrates the distribution of study subjects according to transfusion reaction. So the majority of transfusions in my study were free of any adverse reaction. 2.7% patients experienced itching as a reaction to the transfusion. Rash was reported in 1.3% case. Chills were experienced by 1.3% case. The least common reaction, that is fever, was accounted in 0.7% of case. There was no major transfusion reaction encountered in our study. Discussion. Blood transfusion is a life-saving intervention that is included in the WHO list of essential medications. The conditions requiring transfusion need to be tackled very promptly in order to avoid maternal morbidity and mortality. The main causative factors for maternal mortality in India still remain anemia, hemorrhagia, and sepsis. The study has few limitations. First, since the study is conducted at a single tertiary care center, the findings may not be generalizable to other healthcare settings. Also, the availability of blood product or institutional protocols might influence the transfusion decisions and the outcomes. Second, the study may only evaluate short-term maternal outcomes without following up the patients longitudinally to assess the long-term effect of transfusion practices. The obstetric population in a tertiary center may include mostly the high-risk cases that are referred from other centers as compared to general settings, which may again skew the transfusion rates and indications. Conclusion. The study highlights the critical role of blood transfusion in managing obstetric complication and its impact on maternal outcome. Majority of the patients receiving transfusion had inadequate or no antenatal care. Counseling and prevention of anemia, since adolescents can prevent the prevalence of anemia in women who later on become pregnant. Early and regular antenatal care, early diagnosis of anemia and management, institutional delivery, active management of third stage of labor can further reduce the rate of transfusion in such patients. Overall, the study aligns with existing literature on the indications for transfusion and the demographic characteristic of the patient. These findings stress the importance of personalized care and proactive management in the obstetric settings in order to optimize both maternal and neonatal health. These are my references. Thank you.
Can we have comments from the experts?
Yeah, if you yes, we went through the thesis. Only lacking that. Who was your guide? Who was your guide?
Sir, Dr. Shailesh Kore, sir.
Silas Kore. Is he present? Is he
Yeah.
present?
Sorry, sir.
Has he invited? You have invited him or not? Is he here
Sir, I
with
have
us?
invited, sir.
Okay.
Invited, but I don't see him here.
Okay, no problem. So, all of you know that there are various causes of maternal mortality in obstetrics. But if you have remembered that there is a shift of paradigm of causes of maternal mortality. Earlier, the commonest cause was hemorrhage in obstetrics. The second was the hypertensive disorder of pregnancy, and followed by sepsis and others. But today, there is a shift of paradigm from hemorrhage to hypertensive disorder of pregnancy. In all the Indian studies, especially in the eastern part of Orissa and certain western part of Orissa, like let us say Maharashtra, Madhya Pradesh, Chhattisgarh, Odisha, Bihar, Jharkhand, Northeast, the commonest cause of maternal mortality is now the hypertensive disorder of pregnancy. Next is hemorrhage. If you see the cause being because we have addressed the hemorrhage. How? As you are telling, the prevention of anemia from the beginning. So addressing the anemia from the antenatal period, so prenatal period, and also during the obstetrics, during the delivery intrapartum period also. So prevention, that is managing the third stage of labor adequately. So perhaps these are the factors for which the cause of maternal mortality, the commonest cause is hypertensive disorder, not the hemorrhage. And the other thing you are telling that in the obstetrics, especially, majority of the cases have received only 1 unit of blood. Only 1 unit of blood. That means those cases might be in the not so much in shock, but they are just requiring, let's say, not severe anemia, moderate anemia, but there is hemorrhage. Perhaps this could lead to only 1 unit of blood, as per your saying. So your other expert, Alsila, is there. Pijori is there. So you can comment.
May I ask her one question?
Sheila, welcome.
Yeah, thank you, thank you. Yeah, I will.
Yeah. Tell me.
May I ask her one question, sir? To the presenter?
Yes, ma'am.
Yeah, ma'am.
So,
Tell.
you had mentioned that anemia was the commonest indication for transfusion.
Yes, ma'am.
And one very important conclusion in your study was that if we treat them before, if we make them less anemic by good antenatal care, the transfusion rate will reduce. And so is the complication of blood transfusion, isn't it?
Yes, ma'am.
Can you elaborate on what was the gestation when the anemia was diagnosed? At what level of hemoglobin you gave blood, and how many units was on an average required by these pregnant women? So this will give a more clear picture that how we can dent this problem and reduce the blood transfusion, because this is the only good conclusion from your study which I could gather. More details will be required on this.
Ma'am, good evening, ma'am. Ma'am, actually, my study I also included the pre-transfusion and post-transfusion parameters, including hemoglobin and platelet count, etc. That I have not seen in other studies. So I included that also, and according to the rate of the change in the parameters, our protocols were decided accordingly, like which woman requires more than 1 unit of PCV or requires more number of platelets. So accordingly, we managed them. Like we divided according to the severity of anemia, as in mild, moderate, and severe. That is defined by WHO and ICMR classification, and accordingly we manage them. And also The gestational age I included in my study was less than 37 weeks and more than 37 weeks, like preterm and term patients.
Yeah, but it makes a huge difference that if they are very much anemic before entering into the pregnancy, so they must have been in the first trimester or early second trimester. So that will require more detail. Anyway, thank you.
I think Dr. Nalini pointed out rightly that maximum transfusions are done for anemia. Okay. So now you said there were 9 mortalities.
Yes, ma'am.
Right? Yeah. So what was the, the cause for that mortality?
Ma'am, there were different causes of mortality. Like one I remember is acute myeloid leukemia. She was an known case of acute myeloid leukemia, basically, and she went into chronic plastic crisis. Then second, we had hepatic encephalopathy, hepatic failure, septicemia, septic shock, mostly this way, and disseminated intravascular coagulation. So all these conditions, there was requirement of massive transfusion protocol, but still we lost the patient.
Yeah.
So this
I
were
think
the
only
common
one
causes.
case, I think cryo was given only in one case, right?
Yes, ma'am. That was the patient, acute myeloid leukemia.
Okay, but I know as Dr. Tushar mentioned now that there are a lot of changes now.
Yes.
It is observational study and you have gone through the case sheets, and all of us, we know now that whatever conditions you were telling, there must have been a hypofibrinogenemia or afibrinogenemia, and now
Yes.
there is a shift. Even the revised guideline of WHO is also saying now that if you find that there is a afibrinogenemia, or if the fibrinogen level are less than 200 milligram per deciliter, we should give either cryo or we should give fibrinogen concentrate, which is available. So that is the newer paradigm shift now, even in WHO guideline, because WHO guideline has never earlier mentioned about the methods of or protocols for blood transfusion. It is only the new revised WHO guideline which was released in FIGO on 5th October, and it has come now, so it is included. So that is there, because all those cases, I think DIC, sepsis, as you said, no, encephalopathy, then hepatic, because coagulant factors will not be there, must have been in need of that. And anyway, this was a retrospective analysis, so that is there. So anemia, again, as you said, what was you said between 34 to 37 weeks you have given, right?
Ma'am, preterm and term, and then first trimester, if there were complications like abortion, ectopic pregnancy, suction evacuation, done for
acute problems.
Acute problems, yes, ma'am. That also I have included in my study.
Here, what was your cutoff level of hemoglobin for anemic patient in 34 to 37 weeks for blood transfusion?
Ma'am, for blood transfusion, less than 7, ma'am.
It was less than 7.
Yes.
Yeah, because if it is more than 8 after 36, we don't usually again advise, right? Blood transfusion, if they are nearing date and they are almost 36, 37 weeks. Okay, as it was a observational and retrospective study, I know now with the changing trend and all of us are geared up now, so there should be a better outcome with whatever we are treating. Okay, yeah, thank you.
Thank you.
Okay,
I want to make that. Yeah.
Yes, sir, go ahead. Sir, please go ahead.
No, Sila ma'am has rightly told that now you see earlier we used to give whole blood or even TRBC and all. Nowadays the component therapy has played a lot of role. As you are telling correctly also that you should give platelet or fibrinogen like that. The component of the blood should be encouraged instead of the whole blood. The other part you have told maximum groups where they receive TRBC, isn't it? From your group.
Yes, sir.
Yes, so that is also a very good thing. That of course in all the tertiary institutions nowadays the incidence of TRBC is more, but at the same time the scope of component therapy like platelet, fibrinogen, they are also taking up in a great way. So that's also Sila is also agreeing, and new literature also telling that you go for specific therapy instead of whole blood.
Yes. Dr. Jinal, you have said about the mode of delivery, actually.
Yes, sir.
So just I'd like to see whether you have tried to find out, is there any correlation with your transfusion and mode of delivery? Because you have analyzed the patient's mode of delivery as well. Did you find anything?
No, sir, like there was a
Or
minor
did you evaluate it? This how much patient transfusion, which mode of delivery, or it's I have seen you have mentioned about mode of delivery,
Yes, sir,
or
I
it is
have mentioned.
all the patient you have just mentioned what is the mode of delivery, or like how much patient blood transfusion had this mode of delivery, or this much has this delivery. Did you try to find out with that?
Sir, I have calculated. I had my patients and their mode of delivery, whether it was normal delivery. And first step was to get the patient who received transfusion for any condition. And then I find out how many patients were delivered vaginally and how many were LSCS was done. So my result was that there was no significant difference, like only a minor difference, like 49% in vaginal delivery and 48% in LSCS patient.
Fair enough, fair enough. So, what anything new you find out from your study? Do you feel because you have mentioned quite a few literature, anything new information has got which you may would like to highlight, maybe 1 point or 2 point?
Sir, as compared to other studies, I had seen that no one has compared the pre-transfusion and the post-transfusion parameters. I have included that in my study. And also, second
Yeah,
point,
that's all. The parameters. So, anything significant the difference has got from the previous studies in your parameters?
sir, by finding out the post-transfusion parameter, that will help us to guide if the patient requires further transfusion or not. And so that can also optimize our transfusion protocols. Like unnecessary transfusion will be avoided if we have a pre-transfusion and a post-transfusion parameters to monitor the patient's progress. So that is one thing.
Okay.
And second thing, I also maternal outcomes I have included. And the third thing, I also included the neonatal outcome because overall the maternal outcome also influences the neonatal outcome. So
So,
that
did you get any significant difference in maternal outcome from the previous contemporary studies? That is in our study, in your study, or it is comparable with
sir,
the
it is
previous?
comparable. Sir, I can't say if it is very much different. Like there are some parameters that are comparable with the other studies. And there are these parameters like the number of maternal mortalities were less in my center. But then it all again
Okay.
depends upon the patient load and the risk factors of the different centers.
Okay. Okay, fair enough.
May I add one last point to this discussion, please? Hi, Dr. Hafiz and everybody else. So, I was just private to this discussion about any novelty in the study.
Yeah.
Sometimes we might not, we may not, intervention has not been largely very different. I couldn't hear the presentation initial part, but anemia is a festering problem in our country, and so is PPH. So many times we might end up having the reiteration of what we already know. So research is not reinventing the wheel. Sometimes we may have we may just add to the existing number of results and the sample size by undertaking a study in a different setting or in a different challenging situation. The outcomes might be the same. The intervention might be different. The initial interrogation might also have been different. So sometimes, even though the results, the parameters, biochemical results are almost the same, it doesn't anyway get our study, it doesn't lose value. I'm just trying to say that. It is simply the way we undertake a systematic review. You collate so many results together, identify good and poor quality studies, identify the results of good quality studies, and find a robust evidence. But the only thing is, we from ourselves, when we are planning that research, we should be having our eyes open. It's very important to always consider novelty. That's very important. But sometimes that may not be feasible. And especially for a thesis like scenario, you end up doing many things which have been already done, but where the literature gap is there. So, Tulika, I would say, I would, in fact, suggest to you that you could also frame your answer in this direction. Just
Yes,
my
ma'am.
suggestion. That's it.
Thank you, ma'am.
Yeah, thank you.
Yeah. Yeah. So with permission of chairperson, I would like to comment
Tulita,
on.
yeah. Tulita, what is the type of
Sir, go
study?
ahead.
What is the type of study you call?
The prospective observational study.
Yeah. Okay.
Okay.
How
So
to prove that? How to
yes.
prove that? How to justify that?
Mhm.
You must have collected the cases
Yes,
in the
sir.
speculative time, and you have
Yes.
not
Yeah.
taken
Yes,
the
yes,
data
sir.
behind that.
My
That's
study
not
period
a
was of
retrospective one.
yes, ma'am. My study period was of 18 months. So Jan 23 to June 2024. So I have the consent forms and the case record forms. So it was a prospective study. Like the patient was has got into my study since the time she had received a transfusion for a particular condition till the time she has been
Hmm.
discharged from the hospital.
So it's not a retrospective, it is a prospective and
Yes,
observational
it is a
study.
prospective study.
And observational study, isn't
Yes,
it?
sir.
Okay.
Yes.
Okay, done.
So Dr. Jinal, what seniors are trying to point out here, we are discussing research methodology. Whatever you said just now, those words were not there in your actual study. Your words were the data was collected from the case sheets, case records, registers. Getting my point? See, your study is a prospective
Retrospective.
observational study.
But
Before
it
you
looked
submit it to ethics
retrospective.
committee,
Sunil, you
it
pointed
looks
out rightly.
retrospective.
Yeah.
So such things
Retrospective.
weakens your study. Always remember. So point and message to all postgraduates are take your thesis very seriously. Try to make it robust so that if any person is trying, this will weaken your study as in to include into systematic reviews and meta-analysis. And this is what India is lacking.
Jinal,
Yes.
So
whenever,
take your thesis seriously so that you make it such a strong so that it will actually help in evidence generation. Some researchers sitting worldwide anywhere and trying to include your study, if it is of low quality, it will be discarded. So as Radhika madam started pointing, this is our research methodology and this is critical appraisal of your study. So this is a message to all the postgraduates.
Sir,
Yeah,
sir, I
but,
have sorry.
this actually why you should tell about the what is the type of study. You see, this is required for 3 points of view. Number one, as a postgraduate, whenever you are appearing the exam, we ask the thesis. There are certain marks for this thesis, isn't it? For
Yes, sir.
thesis, so we ask what is the name of your study. Then we ask what is the type of study. Like as you are telling, this is a prospective, but in the initial you have written the retrospective. So prospective observational study. So what do you mean by that? Then we ask. So that is for a postgraduate. Then for the coming to the research one. So research methodology will depend on that type of study, isn't it? Hello,
Yes, sir.
am I audible? So what is the type of study that research methodology? The third most important thing, whenever you are going for publication, that is required, isn't it?
Yes, sir. Sir,
So
I have
that's
written a prospective observational study only in my slide, and the data that was being collected that I have mentioned. So data was like the parity status, the age of the patient. I meant the data by that.
Jinal,
So your
Jinal,
wording.
can I say one thing? When
Yes,
you are
ma'am.
presenting such things is that you are supposed to say if you are the what are the aims, objectives of the study, then
Okay.
study design, study type, the
Yes,
method of collection of data, and the analytical points in that.
Okay.
Then all these questions they will get answered in that. So
Yes.
whenever you are presenting, present with all these headings in that.
These are
Right,
the
Sudhir?
headers.
Okay,
And
I
what
request the experts now. We should move to the next case. Otherwise,
Yes,
Yeah.
yes,
we have one more talk
Yeah,
after this.
we
yes,
should move
yes.
to the
Yeah.
next one.
All the
I just
best.
Yeah, yeah.
exactly.
Okay,
Thank
Jinal,
you.
you presented well.
Well
And
presented.
Thank you, everyone.
Very
yeah,
nice, very
Thank
nice.
can we
yeah, Jinal.
request the
Jinal. Okay, well
experts
done.
to
Thank you,
introduce
sir.
the next speaker,
Good luck.
please? Can one of the experts introduce the next speaker? Nilima, can we have the slide? Can we request the experts to introduce
Sheila
her?
ma'am, can you introduce?
Sheila ma'am?
Yeah, sure. Okay. It is my proud privilege to introduce Dr. Nalini Arora. She is a director, professor, and head of the department at Medical College, Kolkata. That is PGI MSR. And teaching experience is of almost 30 years. And she is a faculty for faculty development program at regional center, and a principal investigator local for the College of ICMR multicentric projects. She has almost 40 national and international publications. She is a reviewer of International Journal of Obstetrics and Gynecology, and she has many awards, and one of that is Dr. Mohinder Kochar Award for Best Paper Presentation in 2018. So over to you, Dr. Nalini. And I think
thank you,
the
madam.
next
Thank you
student-
for
yeah.
your kind words. And I shall be sharing my slides. Kindly give me a minute. My slides are, is it?
They are visible, ma'am. Please do
Yeah.
slide share.
Yeah.
Slideshow.
Fine. Yeah. So the title of my, good evening all once again. Title of my study is Reference Range of Thyroid Hormones in Pregnancy, Customization Needed for Pregnant Women in India. This was a study which is published this year only in JOGI in May-June 2025 and volume 75. So we all know that thyroid dysfunction in pregnancy is reported from 2.5 for hypothyroidism and ranging from 0.1 to 0.4% for hyperthyroidism all over the world. In India, this has been variously reported as ranging from 8.25% to 22%. Actually, my half of the slide is not visible to me as per the various studies from different regions of India. Now, we all know maternal thyroid dysfunction is associated with increased pregnancy complication, neonatal complications, cognitive impairment in childhood. And physiological changes during pregnancy cause alteration in maternal serum thyroid hormones. And many other factors like ethnicity, body mass index have also been reported to influence the reference range of thyroid hormones. And therefore, the diagnosis of thyroid dysfunction is challenging during pregnancy. We searched for the available studies from India. We found few studies. Of this, we found that there are studies which differ in different method of analysis of hormones, like people have used ELISA, people have not excluded anti-TPO antibodies from the reference population. Many studies have very small sample size. And finding these lacunae in the existing literature, we planned this study to establish the trimester-specific reference ranges for serum thyroid function test in asymptomatic, healthy, pregnant women. I'm sorry, the slide is moving very fast in between. So the aim of this study was to find out trimester-specific reference range for free T3, free T4, and TSH among asymptomatic, healthy, pregnant women. And since we are going to exclude the anti-TPO antibody positive patients from our reference population, so this has become our secondary outcome. Okay. So this was a statistical analysis we did, and we used 5th and 95th percentiles for reference range. This is the Beckman-Coulter, which was used for hormonal assay in this study. It's moving very fast. I'm really sorry for it.
They are jumping your slides.
Yeah. I don't know why it is happening. Just a minute. Yeah. It's happening multiple times. Okay. So we enrolled 918 women, pregnant women, asymptomatic, without any risk factor, without any comorbidity. Of these, 76 women were positive for anti-TPO antibodies, and hence these were excluded. In the remaining 842 women, another 6 were excluded because they were overt hypothyroidism. And therefore, the reference population for the studies was 836 asymptomatic pregnant women in different trimesters. So this is the demography. We can see in first trimester, second, nearly similar number of women are enrolled. Majority were from rural, and most of them were primary gravidas, and majority had an income between 5,000 to 10,000. So this is the finding where we can see that the thyroid serum TSH levels in first trimester, second trimester, and third. Can you see my pointer, please? Because this table is little crowded.
Yeah.
So the upper limit is 4.95, 4.9, and 4.59. So this is how we found the 5th and 95th percentiles in 836 women. This is the distribution of different hormones. We can see that this is a skewed distribution. This is not a normal distribution. And that is why we had used percentiles for reference ranges. This is table is almost a repeat where I have given only 5th and 95th percentile, and we can see that the TSH level is more micro international unit per ml, which is higher than the prescribed or recommended value of by the American Thyroid Association of 2017. The mean median values for TSH between each trimester showed no statistically significant difference. No specific trend was seen between FT3 and TSH with advancing gestation. However, free T4 showed a decreasing trend with advancing trimester, which was statistically significant. The prevalence of anti-TPO antibody in asymptomatic women was 8.27%. The mean TSH was significantly higher in these women who were positive for anti-TPO antibodies than those who were negative. Overt hypothyroidism was found in 6, that is 0.65% in asymptomatic pregnant women without any known risk factor. So this is a table where I've tried compiling all the previous available studies from India. So we can see that the 2 of the studies have not excluded anti-TPO antibodies, and 2 of the studies had used a different method, ELISA, not the chemi method. And here we can see that if we exclude these studies who have used ELISA and who have not used anti-TPO antibody as an exclusion criteria, then the range of the TSH in the 3rd trimester is 4.59 from the current study to 4.97 from a study from Raipur by Nanda et al. So this is the range. So it is observed that upper limit of serum thyroid stimulating hormone levels fall within 4.59 to 4.97 micro international unit per ml in 3rd trimester, including the available studies from India. And this value is significantly higher than the recommended upper limit of thyroid stimulating hormone of 4 micro international unit per ml as per American Thyroid Association 2017. The American Thyroid Association also recommends that non-availability of local and ethnic trimester-specific reference range for thyroid hormone during pregnancy, if it is not available, then the lower reference range of TSH can be reduced by approximately 0.4 milliunit per liter, and the upper reference limit can be reduced by approximately 0.5 milliunit per liter for the late 1st trimester of pregnancy. And this range gradually comes towards the non-pregnant range by 2nd and 3rd trimester. And thus applying this statement, if we see that in the current study, the kit value, the kit reference range was from 0.34 to 5 micro IU per ml. So we subtract 0.5 micro IU per ml from the upper range as recommended by the ATA 2017. the value will come to 4.5 micro international unit per ml, which is again found higher than the 4 value. 4 ATA has recommended this value for those countries and those region where local reference range is not available. But since in India we have got few studies, and from there if we derive it again, it comes even higher than 4. And thus, the finding of the current study are consistent with this value of TSH upper level for the pregnant women. So if we calculate this way, again, our findings are corroborating with the ATA recommendation. So to conclude, the current study revealed that trimester-specific reference levels of TSH among pregnant women from India are significantly higher. That is 4 milliunit per liter, which is the recommendation by the ATA. And the results of the current study, along with the literature review, reveals that the cutoff of the upper limit of serum TSH in pregnant women in India may be taken 4.5 micro IU per ml as reference value for diagnosis of hypothyroidism in pregnancy. However, these observations are still insufficient to derive a conclusion for nomogram for whole of Indian population pregnant women. Therefore, further similar studies are required from each region using uniform hormonal assay methods and selection criteria for reference population from where we are going to calculate the reference ranges. So this might help further. So thank you very much for patient hearing. And how to stop it? Escape, minimize. It's gone. Yeah. So I'm done with my presentation.
Yeah, and only ma'am, it's a wonderful presentation.
Thank
but
you,
the
sir.
thing is that you see, as you are telling, the region specific studies are required very much. And especially if you see the compared, have you compared with the South study? How many studies are there from South?
Hello.
Yes, sir.
Naliman?
There is yes, there is one study from South, from Andhra Pradesh,
Yeah.
where it is
Hi,
the
Antonelli.
levels.
WhatsApp ಅಲ್ಲಿ
Yeah.
ಹಾಕ್ತೀನಿ.
It was done in 2018, which is there in my table by Rani et al., where it is
So nice.
3.14. The upper limit in the third trimester is 3.14. This is the only study where, but here, very surprisingly, I have also searched the percentage of the population who are taking iodized salt as per the NFHS 4 and NFHS 5. In Andhra Pradesh, as per NFHS 4 and NFHS 5, it was 81.6% in 4 and 83.1% in 5. So surprisingly, their iodine levels are less and TSH level is also less.
Yeah.
Which
So
should
why
be
I'm telling
opposite. So
yeah, opposite.
I'm not
So,
sure why this type of results have come. This is the only study where the results are, they have used the same method as we have used. They have also excluded anti-TPO antibodies, but still their levels are different. So I'm not sure.
Madam, another observation that let's say, especially eastern part of India, let's say sub-Himalayan area, and also central part like Chhattisgarh, Rajwaru, one study is there, then Madhya Pradesh and North India. What is the pattern of TSH in comparison to ours 4.5 eastern region?
Sir, in Delhi, there is a study in Delhi. If you want, I can reshare my slides or there is a
just tell the that much
okay.
only.
Okay, sir. In the Delhi, there is a study in 2015 by Shekhri et al. They have taken 2.5th and 95th, 97.5th percentiles, and their upper limit is 4.86. In third trimester, it is higher in first trimester for them.
Yeah. So my observation is that perhaps at the eastern India, sub-Himalayan areas, North India, including Delhi, And Central India, almost same 4.5 plus minus something. But South, as I have asked, particularly Andhra, one study you are telling 3.1. Any study from Maharashtra, Gujarat, western side?
Yeah, Gujarat, there is a study where they have used ELISA method, so we exclude it. But there is another study from Nagpur. There is another study from Nagpur by Mankar et al. In 2016. But they had not excluded anti-TPO positive. So their upper level is coming as 5.78.
Oh my God. So they should have
So definitely,
excluded
if
that.
they don't exclude anti-TPO, their values will come higher. Because even in our study, we have seen that
Correct.
the women who were positive for anti-TPO, they had a higher TSH values significantly. There was a significant difference. So the more studies are required actually from South and West, I think.
No, this is barely required because as a clinician, as an obstetrician in pregnancy, as you know, we have to monitor instead of sending them to endocrinologist thyroid, we have to thyroid specialist, we have to deal with the amount of the thyroxine we're giving for the pregnancy trimester wise. So unless there is a standardized TSH level or thyroid function level in India, so we cannot go for the uniform protocol. That is the problem with us. So as you are telling, rightly pointed out, there must be more number of studies and from various area by study, as already you have told, there is low level in south, one study, few more studies from Bangalore Sila ma'am, you can encourage few other south, you can
But
encourage.
I think Indian Thyroid Association have a guidelines now, no? That
Yes.
yeah, we have a guideline that first trimester, I mean, according to the levels of the thyroid and anti-TPO antibodies we do, if the patient is symptomatic. Otherwise, routinely when we do first trimester, we have to treat them to see that the TSH level is 2.5 in first and 3 in second and third trimester. That is there, okay? So the guidelines of Indian Thyroid Association are
No,
there.
madam, may I interrupt here? This is a guideline which Indian Thyroid Association has adopted from American Thyroid Association 2011, and they have not updated it. Whereas in 2017, the guideline ATA itself has updated their own versions, which has not been incorporated probably
Which is
in
not
Indian Thyroid
incorporated.
Guidelines.
They say
Yeah,
4
and in
is,
many
they say
hospitals,
4.
they are still practicing 2.5, whereas even if we follow ATA, we should at least have a cutoff of 4, if not
But
4.5.
no, but all the endocrinologists follow the same. If you listen to endocrinologists, they say 2.5, 3 and 3 because recently I had a combined session with them. Okay. And as you rightly pointed out, 2017 ATA guideline says 4. 4 is the cutoff according to them. So what you are
you should challenge them with that guideline. If they follow one guideline of American Thyroid Association of 2011, then what is wrong with 2017 guideline that they're not reading and following? They are stick to the older guideline. So you must ask them, you must put a query to them, then only it will be clarified. Simply taking what they're following, we can't follow them. We are more expert in dealing with pregnancies, and if we overtreat them, if we are having a wrong cutoffs, we will either overtreat them or undertreat them. So that means we will create an iatrogenic thyrotoxicosis in a woman whose actual TSH should have been 4 or 4.5, and by giving medication, we are bringing it to less than 2.5. We are creating an iatrogenic thyrotoxicosis. So that is why this is a very, very pertinent topic, which should be addressed at multi-centric levels.
Then we should have more studies.
And we should have a one-to-one discussion with endocrinologists also, rather than taking from them. We should discuss with them that why are they going with the older guideline.
Radhika, we will have a master class next year. Nalini, you will be there. We will try to collect the data. Radhika?
Yes, we will.
No, ma'am, I think it's a very wonderful presentation, Nalini, as always. And
thank you.
And in my long years of association with Nalini, I know she's extremely thorough. But then there is a scope for a lot of discussion on this matter. And as ma'am says, I think we can have this on a later date, ma'am, because I think we are running short of time.
Yeah, I think
And
we all are there in ICOG. So we
I
will
have
have
at
a
least
master class with
yeah,
endocrinologist.
Sir.
And
Yeah,
I
with
think
the
that should be.
same data, and I have at least 5 questions to ask to Nalini, which we will discuss later.
Okay,
Okay.
most
So
welcome.
running.
Yeah.
It's
So
already
it's
5.
already running time.
Yeah.
So Nalini, don't forget, even if I forget, call me. Okay.
Yes, madam. Yes,
We
yes,
will go
yes.
ahead with master class.
Yes, yes.
We will,
Thank you
ma'am.
so much
We
for
will
all your
certainly do that.
suggestions, comments. I'm really glad to take it and I feel privileged. Thank you so much.
Thank you, both the speakers. You have dealt both the topics very nicely. One is the transfusion in obstetric practice. The other is the thyroid guidelines in obstetrics and gynec, obstetric only. And only you have done a wonderful job. Thank you very much.
Thank you, sir. Thank you, sir.
At least you have mentioned that yes, it should be a multicentric. More number of studies should be done in the at least 4 zones.
With uniform criteria of selection.
Right. Okay. Thank you. Thanks to all the participants.
Thank you. Thank you, sir. Thank you, everyone.
Yeah, thank you all. Thank you. I
Thank
think
you, speakers
Sujata
and
has left.
experts.
Thank you so much, Parag, for wonderful topics you have selected. Thank you.
Thank you so
Thank
much,
you.
experts and both the speakers. Yeah. Sunil, can we have the next speaker?
This may be useful for you.
So we are going ahead with the next session, which is a talk by a senior obstetrician and gynecologist and faculty. She is professor and HUD at JJ Hospital, Government Medical College, Mumbai, Dr. Rajashri Katke, madam.
Sunil.
Madam, yes, ma'am. So madam is going to talk about the softwares and the methods which are available at our help for manuscript writing. So we welcome
Yes.
you, madam. Kindly go ahead.
Yes. So this is about the professional manuscript writing. So basically, let us have a background. What is the basic communication in the research is that communication itself is a growth
Dr.
of the
Rajeshri, can you
literature.
please make it full slideshow
Slideshow.
presentation?
I'll make
Yeah.
it. I'll make it slideshow from the current slide, right? Okay. The second one, what are the various types of the manuscript based on the content is that one, you can write with the letter of the editor, communication, case reports, case series, case control and the cohort studies, reviews, book chapters and the randomized control trials and the review of the systemic literature. So basically the anatomy of the manuscript depends upon the structural logical flow of the information, content, context and the conclusion in that. So I would like to just show is that the title, the abstract, introduction, methods, results, discussion, and the conclusion. So just a line about every aspect of it. A good title is very important. You should not be more than 15 words or the 100 characters of that. Running titles are now, it is very important to give, it should be a simple, catchy one. And the effective keywords within the title helps into the easy discoveries or on the in the paper and the search engines in the databases of that. So the important thing about the title abstract is that this is the title where you should go for 15 to 20 words. Abstract, it should be a very catchy. This is the first impression, first look of the write up, and these are the keywords, because keywords are very important to show into the databases. And if you can say, if you want to search any topic of that, put the keyword and you will get it the literature about this. So abstract, the abstract, there are the three main question. What does it add to the current literature? What are the future perspectives? And it should be around 250 to 300 words of that. A well balanced information about the in a structured abstract is that it is a background, methods, result, discussion and the conclusion in that. So basically, there are two types of the abstract. One is a structured, where we'll have a background, aims, methods, results, and the conclusion. And unstructured is the one single para that you can add to the. It depends upon the how the journals they are telling us, in that. But 3C concept, this has to be followed. One is a context. In what context the study is there, so what others have reported for that, what is your content and what you are presenting, and what is the message or the conclusion you are giving it to the world. So keywords I have already spoken to you. They are the exactly used in the indexing of the databases like PubMed, Scopus, Embase, and Mesh and all. So this is about the keywords. The introduction, just a one line about what is the important of the introduction is, what are the things which are present into the current literature. So there are 4 paragraphs they have been mentioned. In the first paragraph of the introduction, we should say that what is the known about the area of the study in that. The second paragraph, what is the unknown things are there and how it will correlate with your study. That is the second paragraph. In the third paragraph, what gaps in the literature are there should be fulfilled by their studies to get compared with our studies. And in the fourth paragraph, you should go for that. What are we are going to do to fill up the gaps in that? So it will give the exact idea of lying this. This is the inverted funnel down scheme is that one is the general information about the problem, what is known about it. 1 minute. And second is the what is unknown, what is not done in this study, and what is the gaps in the literature, and what is the rational idea about this. So while manuscript writing, you are supposed to do all these things in one way. Then comes to the methods. Methods is, I don't want to go in detail of that. Study settings. Then what type of the study, whether it's a prospective or the retrospective, what is the study design, the techniques of the sample size and the sampling, and the ethical approvals. Some of the journals, they do want that there has to be a ethical approval is there, or the consent of the patients if you're presenting the case reports or the case series in that. So recruitment methods, at least there has to be a 3 criteria of the inclusion and the exclusion criteria, experimental and the interventional details, statistical analysis, which is very important to go into the methods of that. So in the methods, there are the 3 questions to be, we should think while we're writing: what was done, where it was done, and how it was done. So these are the methods where you are collected the data and you are mentioned about the collections of the data and all. So methods of the 7 areas. So study setting, design, study population, study design, sample size, how much it is, sampling technique, then ethical approvals and the informed consent, then recruitment method, that is the inclusion and exclusion criteria, and all the experimental and the interventions for the reproduction and the statistical analysis. So then comes to the about the results one. The results part is very important because it is the main heart of the manuscript, because whatever the methods are there, you are supposed to study it, analyze the data, and you should come with the conclusion of that. So in the results, you should always written in the past tense without any interpretation. Then the tables and figures is to be drive with the exhaustive thing, and there should not be a repetition of data which is already carried into the tables figures. So you are supposed to come with the results with the proper positioning and the citation of the tables and the figures within the main text. The result section should carry clear descriptive and the interferential statistics. Sometimes the students, they present with the dissertation and all, and the whole 50-100 pages goes, and then it is very difficult to conclude what they want to do, how they want to do, where they have done, and all these things. So the whatever the manuscript writing is there, either for the book or for the chapters or for the paper presentation, it has to be a very clearly and with a scientific base out of it. So what is the interdependence between the methods and the results? So basically, methods means how the data and where it has been accumulated and what are the results, and with this 2 combination of that, you should come with the exact result section, and that gives you the interpretation of the studies in that. Then comes to the discussion of the part. So discussion is, it's always a reverse funnel of things, and in the discussion, you are supposed to discuss all the parts and most of the studies which are very beneficial or positive towards you. Some studies, they are not very positive, or they have a different, study results are there. Then you can compare with that. Just now we have seen that case, some people, they are using with the thyroid, this cutoff level, some of they are using like this. So this is part of the discussion and coming with the proper results in that. So in the pyramid, basically after the method, the key results, your study versus the other studies, then results into the context one by one, then what are the strengths and limitations of your study, and the generalized conclusion that gives the take home messages of our result of our paper or the this thing. So in conclusion, a conclusion should be in communicating three things which the reader should be memorable to take the home message. Take home message has to be very proper in the form of whether added to the literature, what are the future perspective, and how we are going to contribute with the or add to the scientific field of our of that topic in that. So the what is the crux of the conclusion is that what are the final thoughts of your results, then what your study means in going forward, and what this study is going to give to the world in a scientific way. In that, always provide the future perspectives. Never say that okay, this is my study, this is that, and this is it. You have to compare with, sometimes you will get the positive studies results like you, sometimes you may not get the same results with you. Then you are supposed to come with the future perspectives comes in that. Then the part of the references and the bibliography, this I don't go in detail of that. Vanquish system we are using in this. So it comes to the organization of the manuscript package. Whenever there is first you should go with the cover letter, authorship files, title page. I have already explained with the title, abstract, and the keywords. Then what is the main manuscript consists of the main text, references, legends, figures, tables, and the miscellaneous parts, author contribution, acknowledgements, then consent of the patients or the ethical clearance, or all these files in a conventional way. We keep the all separate files, and then we go with the filling of the things in this. So out of scope, if you can say that okay, whenever you are doing a submission, see for the technical checkups, see for the editorial author guidelines, what are there. Every journal has a different things. Then selection of the journal is a different thing. Then review, it will get go to the review in the first stage. Either it will get rejected or they are asking for the modifications. Then review at the second stage, and they are give the they will give the decision of the whether it is accepted or the rejected one. So what is the academic writing? Academic writing is a formal and impersonal aimed at the scholars one. So typical writing features of the academic writing include the formal language, no contractions, use of the third person, avoidance of the interrogative statements, avoidance of the exaggeration, or the avoidance of sweeping generalization. It has to be clear, concise, without any repetitions of that. So there are the some Microsoft Word in that, like Word is there, then Google Docs is there, then there is a Scrivener. The people in the world, they are using most of the things with the Scrivener in that. Plagiarism softwares are there. We are not supposed to use the copyright material the same of that. If suppose you are using some of the thing around 5 to 10%, it is okay in that, but you are supposed to give them the whatever they their credit. You have to give it. Yeah, you can take the permission from that journal and you can use it that. So plagiarism is one of the important part of that. So what are the features? There has to be a familiar text editing, formatting presets, import of that, corkboard, outliner, templates, script writing, tools for the non-fiction, full screen writing, and the metadata collections, and choose your tools. So all these Scrivener and all these softwares, these are the powerful apps for writing, researching, and organizing long documents, and it uses a ring binder metaphor to organize your manuscript. And this is very, very important, because we used to do a lot of homework for the collections going into the journals. Previously, we used to go to the library, find it out, take it in writing and everything. But with all these softwares, in a click, you will get all the information in this. This is the one of the Zotero is the one of the thing in this. So overall, having a basic understanding of these software tools can help the new author to find it, to work or to write more efficiently, effectively, and accurately. Sometimes they say that for the chat GPT, you should not take, means though the chat GPT gives within seconds lots of information, you are supposed to find it, the information, whether it is right or not. So these digital tools can help researchers to organize their research materials and the notes very, very effectively and within short time of that. So there are some disadvantage of using this technology for research is that there is over reliance can lead to a loss of critical thinking and the writing skills is there. Then the internet and other digital tools can be a source of distraction also in that. And while the internet providers access to vast amounts of the information, sometimes there will be a low quality of research and the writing. Not all researchers have access to the necessary technology and the resources. So we have to be use it very practically. So some advantages are there are, and some disadvantage are also there in that. So these are the Scrivener, Microsoft, and Zotero. All these things are there. Grammarly, Quillbot, and all EndNote, all these things. I would like to show you some of the video demonstration of that. So this is the right research edit. This is Scrivener. And you can go to the Google in that, go on that site, click the Scrivener, and all these you should go with the tutorials in that. You can find it out how it can gives with the fiction, non-fiction, research, script writing, and all these things. So whenever you are writing the things, take a blank folder, create a folder, give a title in that, write a my manuscript in that. If you put it as subjects, it will give all the information of that, and you can make all the folders, and you can keep the folders in one file of that. And after that, what you can say that there is a binder, and they bind all the things in that. And that is how the things comes to. Then in a new folder, you can take all of the what you can say that for example, if you want to add the diagrams and the numbers, then you can add the diagrams, members in numbers in that, and the figures in that. Keep it one folder in that, and it will automatically make the things very nicely. And the people are using for the medical research and writing the things, people are using for the writing the books, book chapters. For this is very less time consuming. And if you give suppose you say a diabetes with pregnancy, it will give the hundreds of references to you, and they can correlate. This is a very nice thing. Yeah. So uh, just a minute. Yeah. If you want to add the pictures, so you can add the pictures also in the gallery. So it is coming in a traditional way. We used to keep everything in the browse, and we have to take it out in that. So but here they can give all the comparison and all the things in this. So basically, right research edit is a very important video in this. So I think actually, एक minute. This I'll go to this. Okay. So this is with the software. Now I would like to show you how we have learned and how we are doing it. So whenever you are doing it, we should traditional way. We are going to the Google, going for JOGI. Then we are making everything ready in our files. Everything is there. Then you have to make the all your your profile, login, and everything. And then what you have prepared, all the abstract and all that, you make a file in that. And then after making this, you can read the author's guidelines. Then you can go for there, and you can put a file there, or the submit the manuscript. But for doing this, it becomes a very difficult task, for writing the manuscript and all. But here I'm showing you, this is the traditional way of what we are doing it. And this is the one where you are getting the ready-made softwares in that. You have to put the subjects in that. You will get all the references, all the positive things for your study, all the things they will put it. There are the folders are different in that. You can keep your figures and charts. If you give a data, they will analyze all the things. They will put the charts, pie diagrams, and everything in that. And it's easily within minutes it will give an information what you want, or what you could have see, because we have experience of so many years. So for one writing, we used to do so much of the hard work in that. But here the importance of this app is that it is collectively giving the information. It is taking all the information. It is binding the things, putting the diagrams, putting everything, and making the manuscript or the book chapter or the book in a very nice way in that. So what are the common mistakes authors make in this? So title too long, not consistent, title not smart enough, use of the so many acronyms and abbreviations, abstract is so much of long, we don't know also what we are writing in that. The study is different and the abstract is different. Keywords in that, it should be around 5 to 10 in that, but many keywords, they are not matching to the study, though it becomes very difficult. Means what is the importance of our doing writing the manuscript or doing the research is that this has to be helpful to the world, scientific world in that. Suppose I don't write, if suppose there is a diabetes in pregnancy, if I write only diabetes, then there will not be any citation for the diabetes in pregnancy in that. So we have to be very careful in that. Introduction, it has to be very proper in way. It should not overshoot too much, or there should not be any citing recent or the relevant research in that. The methods I have already explained, but what we should not do is that the study settings, inclusion exclusion criteria, it has to be very particular in that. There should be a clear, concise idea one should get after the end of the results, after giving. That's why the inclusion exclusion is very important in that. Results has to be written in a present tense, it has to be very informative. It should be with there should not be a too much repetition, too much overlapping of the things, or there should not be any missing of the essential data or the analysis of data in that. And the discussion has to be very collaborative. It should be with all the studies. You have to compare all the studies, analyze the data, and come to the conclusion in that. This is the thing. I think my time has been over. I think the references are also, it has to be written very properly in that. So I must go now with this thing. So there are advantage. What I have said about that, you can do it within less of time. We can do effectively, efficiently, and accurately, and you are having lots of references in there. So you can edit your results and methods very nicely with the comparison, and you come to the very good conclusion of that. But at the same time, the disadvantage is that there is no critical thinking, and the writing skills are there. There should be a source of distraction, or sometimes if they give over information in that, then it becomes, there should not be a low quality research and writing. What Sunil was saying, we have enough of the data in India, but unfortunately this data, it's not very properly filled in a database and analyze it properly. That's why, in spite we working very hard in that, but sometimes you don't get sight our things. And also for that, this is a very wonderful thing which has been started by the ICOG with the research methodology. And I'm really thankful to Dr. A.G. Radhika ma'am, the ICOG, Dr. Parag sir, and Dr. Pradnya, Sunil, and Dr. Sheila Mane ma'am, and everyone for the, I think Sujata Dalvi ma'am, for her also. And really thankful you have called me here to share my thoughts on this manuscript, this thing. 1 minute. I would like to thanks to all with saying that after all, the ultimate goals of all research is not objectivity, but the truth. So science itself is a truth, and the truth has to become out of it. How it will come in that, when you will do a research with the all the criteria is in that, then we can come to the proper conclusion. And now people are doing it very nicely in India also, and sometimes we are getting also very good results also. For mine also, I mean, whatever a little amount of the work I did in a research, so now more than 150 countries followed also, and crossed to 500 citations, 100 plus publications. Though we don't have so much of the help in doing all these things, but whatever is there, don't feel that there has to be a meta-analysis or big data and all these things. Even in a private practice, if you get a good case series, case reports, or you can have a studies also with honesty, if you can write it in a scientific way, always the world appreciates, and the world, they do cite our work also. And thank you very much for everyone.
Yeah.
Can we have comments from Dr. Sujata ma'am?
Yeah, Dr. Rajashri, that was a very good presentation. You simplified it. You also showed them what app to use it so that they don't have to struggle. They can just put the topic and the app will be able to do. Of course, there's an app even for correction of grammatical mistakes and everything. which never used to be there. So everything automatically comes up. Plus, you also encourage the people who are in private practice or who have a less number of data, they can present the data as a case series or a case report. That is also of an immense importance. And we have a separate journal for case series and case report. So don't get disheartened. In case the case series or case report is not accepted by a major journal, there are separate journals only for case series, case report. So they can still apply into all that. So thank you for giving everyone an opportunity and of course and guidance how to write the manuscript. Thank you so much. Any comments
Madam,
from Dr.
Madam,
Radhika? Yes,
Radhika ma'am,
Apurva.
Radhika ma'am, Radhika ma'am.
So yeah. So
You can add.
no, I really, I think it was a very well presented within the limited time. A lot of information has been shared. And the important point is you actually went from the traditional
To the
the discourse about how to write a manuscript, followed by the software, and then you came back to the traditional way. So the idea is be cautious, is what you are trying to convey to the youngsters, because we may never feel satisfied using these softwares. I don't know.
yes,
That is the
yes,
way
yes,
we our formative years have gone. So while it would simplify and reduce the time, it is so very important for us to every time when you're writing the thought process and the writing, there is a difference. The writing
yes,
is slower than thought. So you think
yes,
more, and that slowness is what is going to refine it better, is what I feel. Of course, it is
yes, yes,
debatable. Today, I am sure people will debate my thoughts, but you have actually echoed what I thought. But these softwares are also extremely useful. What Dr. Sujata just now told us about the improvement in English language, improvement in a correction of grammar.
grammar,
One
correction
of
of
the
grammar.
important reasons why our manuscripts don't get accepted. English is not our mother tongue. We speak
Hmm.
a different English than
They
any
have
other country. But we have an advantage that we know English. It's not like China that they can't even speak English. So to
yes.
that extent, I think we can use these softwares. Other than the ones that you mentioned, WordTune is one which is also free. So
Hmm.
there are free softwares and paid ones. So
Yes.
like a Quillbot is also for a limited number of words per day. They are free. So
Hmm.
Grammarly is also to that extent free. So these are some of the software which can be used for grammar and language. So thank you so very much, Dr. Rajshri. You really did justice to
Ma'am,
the
thank you.
topic.
Thank you.
Thank
Thank
you.
you. Thank you, ma'am. Thank you. God bless you all. Thank you.
Thank you.
So with this,
You give vote of thanks now.
yeah. I would like to present the vote of thanks. With this, we conclude our FOGSI, ICOG, JOGI research methodology and journal club for this year. And we will be commencing next year, maybe in some newer format. And I'm thankful to both the conveners of today's program, Dr. Sujata Darvi ma'am, Dr. A.G. Radhika. And of course, I would like to thank all the three speakers, Dr. Rajasri, Dr. Jinal, Dr. Nalini. I would like to thank the chairpersons who were experts for this session, Dr. Tushar Kar, Dr. Sheila Mane, Dr. Alka Pandey, and Dr. Hafizur. And of course, we have the blessings from our FOGSI President, Dr. Sunita Tandulwadkar ma'am, and our FOGSI Secretary General, Dr. Suvarna Khadilkar ma'am, and of course, the ICOG chair, Dr. Parag Biniwale sir, he has made it a point to attend all the programs in person, and he stays throughout the program. Thank you so much, sir. And we are also like to thank Nilima. She's been the backbone
Nilima.
for this programs. Smooth coordination for all the ICOG programs and the wonderful audience for their patient listening. Thank you so much. And Dr. Sunil also, he's been the master of ceremony for today's program. So thank you so much, everyone.
Last word from me, Pragnya.
Yes,
So
ma'am.
my heartfelt thanks and gratitude to the entire team. I
Yes.
thoroughly enjoyed all the sessions throughout the year. Special thanks to Dr. Sujata for
Sujata.
being there, always smiling. And of course, Dr. Parag, like you said, always present in all the meetings. And to all the three of you, Pradna, Chengde, Supe, as well as Sunil, you've been the backbone and you really managed the show so well. And for all the faculty experts, of course, yes, they may ensure the success of this program. But it's been a great year and looking forward for some more Dil Mange More for the next year. So thank you.
We'll start from
Thank
February
you. Thank you.
onwards,
Yes, yes, yes.
2026, February.
Surely,
Yes, yes,
ma'am.
Second week of February, Tuesday.
yes.
Okay. And
Yes,
there is
yes.
new leadership, ICOG chair, new chair.
Yeah.
Yes, yes.
Thank you. Thank you so
Thank you, ma'am.
Thank you.
Thank you.
Thank you so much.
Bye.
Thank you,
Thank you so
Pradnya.
much.
Thank
you.
you.
Thank
Thank you,
you.
Radhika. Thanks. Bye.
Thanks. Bye.
Bye.